All right, good afternoon. Thank you for joining us tonight on behalf of Cardiovascular Innovations Foundations. Thank you for joining our discussion on synergy of drugs and device for treating peripheral arterial disease, a concerted approach to improving patient outcomes. To make you aware, this is a CME accredited event, and we'll give you some information a little bit later on how to obtain that CME credit. We're very happy tonight to have two esteemed faculty members, Subhash Banerjee and Dr. Mehdi Shishehbor, who will be panelists. Our speakers for tonight, Dr. Manesh Patel, Dr. Elissa Altin, and Dr. Herbert Aronow. We'll introduce them individually before their talks. My name is Teresa Carman, and I'll be moderating tonight. Please feel free if you have questions during the presentations to put them in the chat box, and we'll try to answer your questions after the talks or at the end of the presentation. I'd like to acknowledge the generous commercial support that we get for this educational activity from Boston Scientific, Medtronic, and Philips. None of the planners have specific disclosures relative to these presentations. This is our agenda for the evening. Dr. Aronow is going to talk to us about defining clinical risk predictors of endovascular peripheral arterial disease patients. Dr. Altin is going to discuss does lower extremity revascularization strategy influence the antithrombotic regimen? And Dr. Patel is going to talk to us about antithrombotic therapy in coronary artery disease, peripheral arterial disease patients, his take home specifically on contemporary evidence. This is how you'll claim your CME credit. Beginning 4/17, you can log in on the website, complete the evaluation, and download or print your credit statement. Please make plans to tune in to the next live CME webinar. That'll be Thursday, May 13th, approximately a month from now, on ultimate structural cases. All right, and with that, we'll leave you with one final thought about additional archived viewings that are available on our website. It's my distinct pleasure to then introduce our first speaker for tonight, Dr. Herbert Aronow, who's the Director of Interventional Cardiology, Lifespan Cardiovascular Institute. He's also the Director of the Clinical Cardio Cath Lab at Rhode Island and Miriam Hospitals in Providence, Rhode Island. He's going to talk to us about defining clinical risk predictors of endovascular PAD patients. Dr. Aronow, thank you.
Terry, thank you very much, and thank you to CVI, Drs. Banerjee, Dr. Shishehbor. It's really a pleasure to be here. As you heard, I'm going to be speaking a little bit about clinical risk prediction in patients with PAD who undergo endovascular procedures. I have no relevant disclosures. I want to first start a little broadly and just place this question in context, clinical risk. I think it's important to understand that the genesis of that risk is that people with atherosclerosis in their lower extremities don't just have atherosclerosis in that vascular bed, but actually often have it elsewhere. These data from the REACH registry really hit that point home, where you can see there's tremendous overlap amongst those with PAD and patients who also have CAD, and between those with PAD and those who have CVD or cerebrovascular disease. In fact, about 1 in 6 patients with atherosclerosis diagnosed in one bed will have symptomatic disease in 1 or 2 other vascular beds as well. And so for this reason, when we talk about risk, we're really talking about the risk of MACE and the risk of MALE. MACE means major adverse cardiovascular events, and typically when we refer to MACE, we mean death, MI, and stroke. MALE, albeit variably defined across registries and trials, generally includes acute limb ischemia, major vascular amputation, and revascularization for CLI or CLTI, otherwise known as critical limb ischemia and chronic limb threatening ischemia. We've also learned from the REACH registry that having PAD puts patients at higher risk than having CAD alone, and in fact, having both together even compounds this risk more. If you look to the far right of this slide, you'll see in these bars, the dark blue is representing patients with CAD alone, the light blue, patients with PAD alone, and the turquoise, patients who have both, you'll see that the risk of cardiovascular death, MI, stroke, and hospitalization over 1 year in this registry escalated as patients had PAD or the combination. So clearly patients who undergo endovascular therapies and who obviously have PAD are going to be very high risk patients for MACE. Now, there are things that we can do at the bedside to try to risk stratify these patients. And a great example of that is this set of data, almost 30,000 patients from the COMPASS trial. Here, investigators looked at risk factor burden. Specifically, they looked at patients' BMI and their physical activity, whether they had diabetes or smoking, whether they were hypertensive or dyslipidemic. And if they had 0 to 1 risk factors over this 36-month period, what they observed was that they were at the lowest risk of cardiovascular death, stroke, or MI. But at the other end of the spectrum, if they had 4 to 6 of these risk factors, they were at quite high risk, about over 10% chance of having cardiovascular death, stroke, or MI. And in fact, those who had 4 to 6 risk factors were almost twice as likely as those with 0 to 1 risk factor to suffer one of these events over time. So again, whether it's CAD or PAD, patients with a greater risk factor burden, certainly we can identify them as having a greater risk for events over time and perhaps stratify them to therapies. That's exactly what this slide here shows. These data from the COMPASS trial indicate that as you move from risk factor category 0 to 1 factors to 2 to 3 to 4 to 6, that not only does the risk of events increase, as I showed you on the prior slide, but the actual risk reduction afforded by therapies, in this case, it's dual pathway inhibition with aspirin and low-dose rivaroxaban, we see that the absolute risk reduction is greatest in those with the greatest risk factor burden. And interestingly, even the hazard risk reduction is greatest in those highest risk patients. So again, identifying these high-risk patients may be very helpful from the standpoint of triaging patients to therapy. Now, this COMPASS trial I've been speaking to included patients with CAD and PAD, but I want to kind of carve out the PAD patients since that's the focus of our discussion this evening. And if you look on the right side of the slide, in this panel, on the left side of the panel, you'll see the PAD patients. And what I think will jump out at you is that those with PAD had a higher risk than those on the right side of this panel with CAD. And in fact, the benefit from therapy, and in this case, this was, again, dual pathway inhibition with aspirin and rivaroxaban, was much greater than it was in the patients with CAD. There was a very nice study done looking at male, right? And male is important. It's not just about MACE. I think I highlighted earlier that when we talk about events, we're talking about both major adverse limb events and major adverse cardiovascular events. So there was a very nice study done by Connie Hess and colleagues. They looked at almost 400,000 patients in the Premier database who had undergone revascularization for PAD, and they followed them for a year. About a quarter of these patients had CLI, about 3% ALI, and the rest had claudication. About 2/3 were treated in the inpatient setting, and almost 3/4 underwent endovascular therapy, the focus of tonight's conversation. And so their primary outcome that they studied was male, which they defined as hospitalization for ALI, major amputation, or surgical revascularization. So I've highlighted with red the boxes below that indicate what happened to these patients over the following year. And it's interesting. So their primary outcome occurred in about 10% of patients. So about 1 in 10 patients were admitted for male within a year of revascularization, lower extremity revascularization. But the story is even more concerning than that, because if you look at any limb-related outcome, again, male is sometimes a somewhat narrow definition, but any limb-related outcome, almost 1 in 5 patients were admitted within 1 year of an initial revascularization procedure. Contrast that with cardiovascular events, which again are very important. You'll notice that only about 13% or so of patients were admitted with cardiovascular events. So it's important not to minimize or not to underestimate the importance of limb-related events over time after lower extremity revascularization. In a sub-study of COMPASS that included almost 6,400 patients with PAD, Anand and her colleagues identified a number of factors that might predict male. Included among those were Fontaine classification 3 or 4 ischemia, so those are your CLI, CLTI patients. A history of peripheral revascularization surgery or angioplasty, and prior amputation. There's been a lot more work done looking at this. And in fact, if we look at that premier data set again, we can identify independent predictors of male over 1 year. And not surprisingly, older age, male gender, Black race, insurance status, they all predict a higher likelihood of male over time. There are also comorbidities that do as well. So renal insufficiency and prior stroke or TIA, having diabetes or heart failure, and even smoking. There are also the clinical presentation, it plays a role. So you might imagine that somebody with ALI would have a much higher risk than someone with claudication, or someone with CLI would as well. Surgery, interestingly, had a higher risk than endovascular therapy for developing male over the year after that procedure. And there were across specialty differences that were interesting as well. We don't have as much data looking at predictors of male over longer periods of time, but these data from the OLIVE registry looked at 3-year male after endovascular therapy for infrainguinal PAD and identified statins as being associated with a lower risk, and straight line flow or establishing straight line flow to the foot as being associated with a lower risk, while they identified higher Rutherford classification and heart failure as predictors of greater risk of male over time. And in this interesting sub-study from Compass in over 4,000 patients looking at MACE, at male, and bleeding at 30 months, Kaplovich and colleagues identified a number of features which they referred to as high-risk limb presentations. That included Fontaine class 3 or 4, prior lower extremity revascularization, or amputation. And they also looked at what they referred to as high-risk comorbidities. So that would be polyvascular disease or atherosclerosis in multiple beds, diabetes, heart failure, or kidney insufficiency. And when they looked at whether patients had one of these, both of these, or neither of these, the findings were interesting. And you can see them on the right side of the slide here. If I were to direct your attention to this set of bars here, these are patients at highest risk. They have both high-risk limb presentations and high-risk comorbidities. You'll see that the risk of MACE in male was highest in this group compared to the other group with either alone, and certainly much more than those who had neither. In fact, the risk reduction with therapy, again, this is a study of dual pathway inhibition, was greatest in those who had both high-risk limb presentations and high-risk comorbidities. So again, there certainly are features from risk factors to clinical presentation and such that can help us identify patients who are at risk over time. Voyager, which is a study that I know Dr. Patel will speak to later this evening, I think it is an example of how we can identify patients who are at risk. That is, patients with PAD who undergo endovascular therapy will be at lower risk if they're treated with dual pathway inhibition than if they're treated with placebo. And again, I know you'll hear much more about that. So I want to run through a couple of cases real quickly and just get your thoughts on what you would do here. So imagine a 67-year-old with diabetes, heart failure, CKD, coronary disease, cerebrovascular disease, who underwent a right transmetatarsal amputation for gangrene in the past. He now undergoes a right FemPop lithotripsy and drug-coated balloon for rest pain. In addition to a statin and RAS inhibition, he should be treated with A, rivaroxaban alone, B, rivaroxaban and aspirin, or C, aspirin alone. I think, based on the data I reviewed with you, that he has a number of high-risk features. These include comorbidities like diabetes and heart failure, CKD, evidence of polyvascular disease, and that he's got atherosclerosis in his coronaries and his cerebral vasculature. He's undergone a prior amputation as well. And now he's undergoing endovascular therapy as well for FemPop disease in a clinical presentation that would be considered CLI or CLTI. So all of these are high-risk features. My take on this patient, and I'd be interested to hear yours, is that this is somebody who clearly would benefit more from an approach that was combination therapy, as evidenced by Compass and by Voyager than by either of these therapies alone. Another patient, a 55-year-old female with hypertension who is engaged in supervised exercise therapy for intermittent claudication from severe proximal left common iliac artery disease. So which agent should be administered? You can choose all that apply: a statin, an ACE inhibitor, clopidogrel monotherapy, or rivaroxaban and aspirin. Here, I would consider this patient to be much lower risk than the patient I presented to you previously. And I would argue it's not as clear that dual pathway inhibition is needed in this patient. Others may argue to the contrary. And again, I'd welcome your thoughts. But I think we know for certain that statins will reduce atherothrombotic events, will reduce MACE and MALE in this population, that ACE inhibitors will reduce MACE as well, and that antiplatelet therapy is indicated. And from way back when, we know in the Capri trial that clopidogrel monotherapy was superior to aspirin monotherapy. So that was the rationale for my answer. I'd like to conclude with the following. Patients with PAD are at elevated risk for atherothrombotic events, especially following revascularization, including endovascular therapy. Multiple clinical risk factors have been identified and can be applied at the bedside for prognostication, as well as to help guide therapeutic decision-making. Thank you very much.
Thank you, Dr. Aronow. Let me ask just one question based on the data you presented. It would seem that, at least logically, much of the decisions made around instituting dual pathway therapy with rivaroxaban and aspirin might be individualized at the time of intervention. But what are your thoughts with respect to having EMR recommendations that can be built in, some logic that can be built into an EMR to allow you to make those decision pathways? Do you think that that's reasonable or forthcoming?
So I think that's a great question, Terry. And I say that knowing that nobody who's using an EMR right now or an EHR wants another prompt, right? I mean, we're all trying to minimize the number of clicks and the number of interruptions, but I think one of the issues that we have, really two of the issues that we have are both safety and effectiveness with the therapies that we should provide to our patients. And so certainly prompts that might help us avoid prescribing a therapy that could be harmful would be useful, and prompts that might motivate us to initiate a therapy that perhaps otherwise we wouldn't have thought to initiate would be useful. And I think that there's a little bit of medical therapy fatigue out there, maybe, right? We've got all these medical therapies we place our patients on. They're all really important, but I think the inertia needed to place them on an additional therapy is greater once they're already on a number of agents. And so it's really important to get them on the right drugs, but I think we may have to work a little bit harder in 2021 to do so. And so if that takes a prompt, just to remind someone of the evidence base that supports, for example, dual pathway inhibition, then I would support that.
Perfect. All right, thanks. Just as a reminder, if you've recently joined the program, please put any questions you might have into the chat. We'll try to address questions. We should have about 15 minutes or so at the end of our presentations. Next, we're going to hear from Dr. Altin on does lower extremity revascularization strategy influence the antithrombotic regimen? Dr. Altin is an interventional cardiologist from Yale University and VA Connecticut in New Haven, Connecticut. Thank you, Dr. Altin.
Thank you, Terry, and thank you to the planners for inviting me to speak on this topic. So I'll start with this roadmap. First, we're going to discuss what Herb had talked about. The patients are at higher risk of atherothrombotic events after PVI, and this represents a balance of MACE and MALE. Then we're going to talk about the atherothrombotic therapies available post-PVI. And then we're going to have two case presentations. Case one, that is a patient that has an excess MALE risk, and case two of a patient with an excess MACE risk. So the risk of atherothrombotic events post-PVI is high. 1 in 5 patients by 28 months after PVI will have experienced a cardiovascular or a limb event. And they have a 4 times higher risk of ALI compared to those patients who were never intervened upon. So this is a helpful framework to conceptualize the risk. Essentially, MACE stays the same after PVI or with chronic PAD, good secondary prevention, but it's male that increases, the male risk increases post-PVI. As far as antithrombotic therapies after PVI, you have some options. You can give dual antiplatelet therapy, which is analogized from the coronary strategy. You can give antiplatelet monotherapy or anticoagulation with an antiplatelet monotherapy. And the decision about which drug to use is essentially based on the mechanism of what that thrombotic risk post-PVI is to that particular patient. So this, again, back to this balance of MACE versus male. So the COMPASS trial looked at all comers with peripheral artery disease and showed that compared to aspirin alone, the combination of aspirin and a low dose rivaroxaban BID decreased the total peripheral artery outcomes by 25% almost. And MACE and male were decreased compared to aspirin alone without any increase in life-threatening bleeding. Voyager PAD took a specific population of patients post-revascularization and compared the same drug regimens and found that rivaroxaban low dose and aspirin had a lower incidence of the composite outcome that included ALI, amputation, MI, stroke, and cardiovascular death. And Herb showed this, but preventing male is absolutely key because by the time you have a male event, it's not just that you've had the male event, but you have a 3 times increased risk of death and a 200 times increased risk of subsequent amputation. So a male event has a morbidity and a mortality. And what about the predictors of MACE after revascularization? So in this study, they looked at the biggest predictors, and they found that dialysis was one, having lower extremity bypass versus compared to an endovascular procedure, COPD, diabetes, tibial revascularization, and concomitant beta blocker therapy all portended more risk of MACE. So now we're going to move on to the case presentations. Case 1 is a patient with an excess male risk. So this is a 70-year-old man with HIV, diabetes, hypertension, and smoking with recent cessation. He had debilitating claudication despite having quit smoking and participating in supervised exercise therapy. He was on HART, a high-dose statin, aspirin, and lisinopril. His ABIs were normal on the left, but his right was 0.54 and his toe pressures were on the low end at 54. His physical exam was notable for biphasic popliteals bilaterally. His DP was monophasic on the right, biphasic on the left. His PT was absent on the right and monophasic on the left. So on this diagnostic angiogram, I didn't show you the iliacs, which were patent, but you can see that the right SFA is totally occluded osteally, and there's well-developed profunda collaterals that fill in this CTO island in the mid-SFA, and then following that, the entire distal SFA is out. He has reconstitution in the popliteal and probably some post-surgical popliteal changes from this rod placement and a lot of geniculate collaterals to his tibials. A 6 French long sheath was inserted from the contralateral groin. The CTO was crossed with a navicross and an angled glide wire in antegrade fashion. This SFA was pre-dilated with a 5 by 100 millimeter balloon, and it was treated with a 6 by 120 millimeter drug-eluting balloon. Following this, there were flow-limiting distal SFA and osteal SFA dissections that were treated with life stents in those 2 areas. So you can see here the osteal SFA patent and stented, and the distal SFA stented just above P1. So he was discharged on 3 months of dual antiplatelet therapy. He did well for a few months, and then he slowly started feeling this return of claudication, but then had some subacute leg tingling. He was brought back for an angiogram, and you can see that the SFA has occluded from ostial down to the P1 segment. ECOS was initiated, and flow was restored. He was discharged on a full dose rivaroxaban after this thrombotic event. He did well for almost a year. But around the end of that year mark, he missed a few doses of rivaroxaban, and he started smoking. And that week, he had acutely right cold leg. He came back for another angio, and it revealed again a thrombotic SFA occlusion, but this time there was extension of disease down into his popliteal, and he was referred to surgery. He had a fem below knee pop bypass and was doing well for a while, until he presented again with the leg tingling and the return of claudication. And you can see here that his SFA, his fempop bypass had acutely thrombosed, as had, and he still had the SFA CTO. And he has pretty good outflow into the foot and a near complete pedal loop. So the question here is, should we have started with anticoagulant to begin with? He had a long segment CTO, although it was attempted to minimize the number of stents placed. There were still flow limiting dissections ostially and distally that required stenting. So given that he was prone to thrombotic occlusion, his tibial outflow was okay, but not wonderful. Should we have started with anticoagulation first? So in this study from Dr. Banerjee and colleagues from the XL-PAD registry, actually SFA CTO recanalization is associated with increased stent thrombosis rates, almost 4 times the rates of those SFA lesions that are non-CTO. And when we look at the balance of MACE and male after stent thrombosis, you can see in the first curve, the red line is the patients who had stent thrombosis, and the blue line is patients who didn't have stent thrombosis. So amongst those patients who had stent thrombosis, they had increased male rates and actually pretty similar MACE rates. So our next case presentation is a patient who had an excess MACE risk. So this is a 72-year-old man, also with HIV, with asymptomatic carotid stenosis, hypertension, hyperlipidemia, subclinical CAD diagnosed by coronary calcium on a CAT scan, chronic kidney disease on hemodialysis with a non-healing right TMA amputation site. He was on aspirin and atorvastatin at baseline. His physical exam was notable for carotid bruit. He had a 1+ bilateral popliteal, and both were triphasic. And his right DP and PT were monophasic. So his iliacs again were patent, and you can see on this diagnostic angiogram that his fempop segments are patent if not diseased. And he has disease in his ostial AT with a total occlusion past the prox segment. His PT is totally occluded proximally, and his peritoneal provides flow down into the foot and reconstitutes the DP and the PT, and it appears that he has an incomplete pedal loop. So a 6 French long sheath was advanced from the contralateral access site. The PT was crossed with a Fielder FC and a Corsair into the foot. A 2.5x220 balloon was used across the PT from the foot backwards, and a 3x220 millimeter was used above the ankle. Following this, the DP was accessed with the same Fielder and Corsair, and the same balloons were used to PTA 2.5 into the foot and a 3.0 proximally. He was discharged on aspirin and Plavix until the wound healed. And you can see that he has good 3-vessel runoff into the foot and an incomplete pedal loop at the site of his TMA. So while his TMA site was healing, he had a VF arrest. And at that time, he was found to have triple vessel disease. Due to all of his concomitant illnesses, he was deemed too high surgical risk for CABG and underwent PCI. He had left main stenting into his prox LED, OM1 stenting, and his mid and distal RCA were stented. And over the course of the next few months, he was having a stable angina syndrome that then escalated, and he represented with an NSTEMI and ongoing chest pain. And you can see the malignant progression of his coronary artery disease. So for this gentleman, he was optimized after PCI and 1 year of DAPT, which was a continuation after the PVI. The wound healed and his chronic CAD symptoms remained stable at this time. So the question in this case is, with isolated tibial disease, no stent left behind, was a dual antiplatelet strategy alone sufficient? And I'll remind us of these predictors of Mace after revascularization. He had a lot of these. He was dialysis dependent. He had diabetes. He underwent tibial revascularization, and he was on concomitant beta blocker therapy. So in this case, I think it may be appropriate to leave him chronically on dual antiplatelets after this tibial PVI. So to summarize, the decisions around antithrombotic choices after PVI must be patient specific, and we need to account for the risk factors of MACE and male. And these include procedural specifics and the concern for development of ALI in those patients at the highest risk of MACE events who have non-complicated PVI. You could consider DAPT, although the data is scant, but I would favor stopping one of the antiplatelets for a low dose DOAC. And certainly in those patients at the highest risk of male, we should definitely consider low dose DOAC and antiplatelet as first line. Thanks very much.
All right, thank you. That was outstanding, Dr. Altin. I think in the interest of time, I'm going to move on to the third speaker. Again, please place any questions you might have into the chat box, and we will discuss those. Our next speaker is Dr. Patel, who's going to discuss the antithrombotic therapy in coronary artery disease and peripheral arterial disease patients. He's going to review his take-home points on the contemporary evidence. He is currently the Chief of Cardiology at Duke University in Durham in North Carolina. Thank you, Dr. Patel.
Well, thank you, and thanks everybody for joining. I know it's in the evening, so I'll try to make this hopefully interesting and exciting as we get to our cases. I'll cover some of the same topics, but hopefully try to bring it home. My disclosures are I was involved in some of the clinical trials involved with some of the antiplatelets and some of the antithrombotics. So I'll start with a case. It's not a case that different than maybe what Herb showed you, and we'll see if their decision-making is the same. So a 78-year-old woman with life-limiting claudication. Interestingly, she's got hypertension, tobacco use, and she did have a PCI, not in the AMI setting in 2016. She's had a left SFA intervention in the past. She's on aspirin, atorvastatin, has tried cilostazol, although most of us have tried this in the past. It's not great work. And then ABI was 0.62. And we knew that she probably didn't have, she's obviously had some sort of progression of her iliacs, as you can see, as these movies will play that. In fact, the iliac is occluded. The SFA actually looks good from where it was, just ballooned. So I'm going to see if I can keep going here. So again, just a total left iliac occlusion with the idea that you would maybe try to go both retrograde and antegrade on this intervention. So a sheath is placed, and then from above fairly easily with a standard sort of glide wire practice is crossed, balloon angioplasty is performed, and a balloon expandable stents placed in a fairly long, not super long occlusion of the iliacs. So we've all come to saying, okay, well, what are the things that help us make these decisions? Is it a drug-coated product? Is it patient's risk? What would you do after to treat this patient? I've given you a few more choices, and I'm going to use these choices to try to just walk us through the evidence. Aspirin by itself, aspirin and clopidogrel, aspirin and ticagrelor, aspirin specifically with rivaroxaban as the studied DOAC, 2.5 BID, clopidogrel by itself, or ticagrelor by itself, Now, why do I say all those crazy choices? I mean, at the end of the night, do you really need that many choices? Well, I guess my theme for tonight's talk is that we're moving from a platelet-centric world to an antithrombotic world. I grew up in cardiology where Jimmy Chang at our institution and others told me, whenever there's a problem in an artery, if you can get more antiplatelet therapy, people do better. And that was very coronary based. And as we think about what we now think about coronary and vascular disease, maybe that's not exactly true. And I'm going to go through chronic CAD plus PAD, and then the post-peripheral revascularization. And I'll try to go through some of these trials. There's Capri, Charisma, Adapt, Compass you've heard of, and Voyager. But I'm going to talk about a little bit about Euclid, just one slide to say, what have we learned? So this is Capri from a presentation I made. And you all may remember now, 20 years ago, we studied aspirin versus clopidogrel was the new drug on the block. And just reminding you that even when clopidogrel, which is a stronger antiplatelet, head-to-head against aspirin and as a monotherapy in chronic vascular disease, coronary, peripheral, stroke patients, it was better, but not by a lot, right? If you just think about that absolute risk reduction of 0.5%, relative risk reduction of 8%, it's better, but it wasn't dramatically better than aspirin. The PAD patients did seem to do better. So monotherapy clopidogrel is superior to aspirin in patients with prior atherosclerotic disease, and it's currently indicated for PAD patients. How about 2 versus 1? This is Charisma, aspirin and clopidogrel versus placebo and aspirin. And again, a 0.5% relative risk reduction, absolute risk reduction. Here, it's not statistically significant, even though thousands of patients were studied. Now, there were some diabetic patients and others. Now, 15 years ago. And so at least when we looked at bleeding at that time, and gusto severe bleeding is not small, it was increased with aspirin and clopidogrel versus placebo and aspirin. And moderate bleeding was certainly significantly increased. So I would have said at that time, most people said dual antiplatelet therapy chronically in patients with coronary disease, not patients who just had a coronary stent or AMI. Clopidogrel and aspirin was not better than placebo and aspirin for chronic vascular disease. So that's important to recognize with an increase in moderate gusto bleeding. And then there was the Dpt trial. And why did we do the Dpt trial? Because we did have drug-eluting stents in the coronary tree where we had late stent thrombosis, and we said, we have to see if long-term therapy is better. And in fact, long-term therapy did reduce stent thrombosis and did have a statistically significant reduction in MACE, but no difference in mortality. In fact, mortality sort of seemed to go the other direction, and bleeding was increased. So we had to make a decision. You have to make sort of a decision about sort of risk benefit for your patient. And at that time, post-MI, we know that acutely 2 antiplatelet therapy is better when we stent someone and they have an acute MI, but this is Pegasus from Mark Banaka, greater than a year out, 1 to 3 years post-MI patients. If you add ticagrelor compared to aspirin alone, they do better. There is a bleeding risk, but they do better. And the guidelines, from the sort of, they've all changed, and I guess they're all moving at this time. But what I would say is ACS or stable ischemic heart disease greater than 12 months. I'm going to focus sort of on the chronicity there. If there's no high risk of bleeding, there's a DAPT score. You may be reasonable. It's a 2B consideration. So I would say dual antiplatelet therapy from 12 months to 36 months is marginally better than placebo. You might say even statistically and significantly better than some patients, but you'd have to think about the risk benefit of bleeding and making sure they're not bleeding. Remember in that trial, they all had to get to 12 months without having a problem with DAPT. So you sort of selected the people that can then live a year on DAPT, what I'll call the bleeding stress test before you actually give them DAPT. Well, this is a trial not a lot of people talk about, although I'll tell you, when we started it and I was participating in this, we thought we were going to beat the heck out of clopidogrel because we thought a stronger antiplatelet agent, and nobody would argue that ticagrelor is a stronger antiplatelet agent in PAD patients, had no effect on MACE. And actually, we looked at male too and didn't have a big effect on male. Now, these weren't patients who just had a revascularization, but these were patients that had claudication or had a history of revascularization. 50% of these had had a prior peripheral surgery or revascularization procedure. So at least I will tell you, not just me, but other smart people thought more antiplatelet therapy in PAD was better. And certainly at that time, chronically, it wasn't dramatically better. Bleeding rates were somewhat similar. So monotherapy ticagrelor was not better than clopidogrel. Chronic PAD, both IC patients and those with revasc. Now, it's important to recognize about 30% of those patients had concomitant CAD. They weren't broadly polyvascular, but they had similar bleeding and efficacy agents rates. And I'll tell you, for me personally, it was sort of an interesting, important moment to think about. The platelet is needed to be inhibited when you are actively disrupting the vessel, but in the chronic antithrombotic state, it may not be as big a player. Talk about the emphasis on antiplatelets and platelets these days with, unfortunately, the vaccine news and thinking about platelet and vascular endothelium. We're all sort of making sure we understand this biology. So Skylar Jones and I put this in JACC a few years ago, and I would say this is really interesting. At the center of this diagram is the platelet, and all the agents we studied, Vorapaxar, Clopidogrel, Prasugrel, Ticagrelor, Cangalor, Aspirin. So we've spent a lot of time on those platelets. But now Revascularization, the 10A inhibitors have come, and it's important to recognize that those do have a thrombotic effect and they do have an effect on the platelet. And so that dual pathway might play a role for brain, heart, and limb events. And if you would have told me before the COMPASS trial was started, and I remember I'm not part of the investigator group there, but I thought it was too ambitious. You were going to study everybody who had CAD and PAD and compare aspirin to Rivo or Rivo 2.5 BID plus aspirin, and you were going to show cardiovascular events in 24,000 patients. I was a little bit hesitant to believe it would work. I'll just say that the trial was stopped for a mortality benefit. Maybe it was stopped too early, although I'll just say it's statistically significant. It holds out to be true. And the hazard ratio in those chronic CAD, PAD patients, as you've seen, is 0.76. Now, it's important to recognize everyone had CAD. Many of the patients had PAD. So they're polyvascular patients. As Herb has already gone through, many high-risk features, but they did have a significant benefit. And unfortunately, what I would have hoped if they'd gone longer is that Riv arm by itself starts to separate. You would have loved to get to a monotherapy antithrombotic version in this trial to see if that works. What about the PAD patients? That's what we care about here. They were broadly defined symptomatic PAD limbs, but they also had carotid disease or a low ABI, 7,400 patients, bigger than most of the studies we would have looked at. And if you look again at the PAD patients, their event rates are higher on aspirin, 6.9 versus 5.6, but their treatment and hazard ratios even more powerful at 0.72. And male, there weren't many events, but again, significantly reduced. A 1% absolute risk reduction in limb events, a 0.5% absolute risk reduction in major amputation, although very few numbers in this study. But overall, makes us think that there's a MACE, male, or major amputation across all the PAD patients. You've seen this graph already from Connie Hess, Mark Banach, and others that your risk for MACE is constant, but your risk for limb events is very acute after an intervention. And that led us to work together to think about the Voyager trial. Just to remind you all, 6,500 patients randomized to placebo or 2.5 milligrams of rivaroxaban on top of aspirin. Clopidogrel was used at investigator discretion anywhere up to 6 months. Most of the time it was used to 30 days. And when it was used in conjunction, didn't seem to have a big effect on the findings, which I'll show you in a second. This is maybe the most powerful finding slide, which is the summary slide, which showed us, I guess, when we first looked at these, that at 3 years, 20% of the patients you do a PVI on have a MACE or male event. 1 in 5 of your patients that you do a peripheral intervention on, the one I just showed you, at 3 years is going to have a MACE or male event. And you could reduce that by a 2.6% absolute risk reduction if you use the dual pathway therapy. There was a price to pay, like always, on bleeding. It's not statistically significant, but the trend is numerically there. And of course, when you look at other bleeding rates, it is an increase of almost 1%, but not quite. Interestingly, when you look at the events, they're driven by limb events. There's no, there's ischemic stroke and myocardial infarction seem to go that way. People have said, Manesh, why is CV death not go the right direction? I think the older you get, the more PAD you have, the more reasons your death, which we call CV death, may be a wide variety of things that are not modifiable in older patients, but just a thought on my part. Here's the sort of best slide I have from Voyager, which is risk benefit, primary efficacy outcome per 1,000 patients. You reduce 181 events per 1,000 patients at a risk of 29 bleeding events, and very, very few or no change in intracranial hemorrhage or fatal bleeding. So if you're going to use dual pathway post revascularization in Voyager, this is the benefit risk you're seeing. How about endovascular patients? I presented this at AHA last year. They don't have as high a risk as the surgical patients, but they have certainly some of the same consistency, no p-value for interaction. So here's what I think about antiplatelet antithrombotic. If you're going to do something to blow up something in a coronary artery and you're going to disrupt a small vessel, then you do need dual antiplatelet therapy. You could argue that below the knee. You could argue that in the peripheral space. I'm not suggesting you're wrong. But if you do that in the peripheral space, we know that if you add rivaroxaban on top of whatever you're doing, whether it's aspirin and clopidogrel, short-term and then long-term continuing that rivaroxaban, there seems to be a benefit. Chronic vascular disease prevention, more antiplatelet therapy does not seem to be dramatically better. So that goes back to sort of our changing paradigm. So here are my conclusions. I told you monotherapy, clopidogrel is slightly better than aspirin. In chronic PAD, CAD, I think aspirin and riva is superior for most clinical outcomes. DAPT is a risk-benefit analysis driven most by MACE, as you just heard prior talk, and it's really post-MI, post-PCI. Post-PVI, if you're using aspirin or aspirin plus clopidogrel, if you really want long-term prevention, you're likely going to soon be adding rivaroxaban. And in 5 years, when these are generic, or 10 years when they're generic, I suspect we're going to be using it a lot more. We now, thankfully, have the data that should drive our decisions. For many years, we were working on just thinking about things from the coronary tree. So now we have some evidence. I'll end with this slide from Jeffrey Berger. I've told you about all the evidence, but really the science is in applying the evidence. We've known antiplatelet therapy and statins might help our patients, and smoking cessation might help our patients. The red bar is PAD plus CAD, and the blue bar is PAD alone in outpatient practice. So 40% of our patients with PAD are getting a statin or less. So I'll just start by saying we talked about the new data, but we certainly got to keep doing the stuff that we know already works also on our patients. I'll stop there, and thank you for letting me have the opportunity to present these cases.
I think we had three really wonderful presentations. Dr. Patel, thank you very much for addressing the idea that we really do undermanage our PAD patients to begin with. I think that's a chronic problem. We can always talk about what can we do better, but just making sure that those patients are on the most aggressive statin therapy and the most aggressive medical management that they can be, I think is our first place. So we have three questions that have come in. The first one was, is there any data on DAPT for PAD? And I think Dr. Patel, you did a very good job addressing that. What about DAPT versus rivaroxaban and aspirin? Is that out there, or is it coming, or do we know?
I'm happy to jump in there and try to answer that. I mean, I wish we could, you having done some of these trials, you always wonder and wish you learned things, right? So what would I have done different for Euclid? I wish I could have gotten an aspirin arm. We really did push hard, but you can imagine with a sponsor doing a 3-arm trial is hard. But that would forever have defined aspirin versus clopidogrel versus ticagrelor and given you the gradient, if you will, of antiplatelet therapy and what's valuable. I'm not sure we'll ever have that answer. In Voyager, we strongly talked about, could we get the third randomized arm of DAPT? Again, complicated because of our own bias. You won't be shocked that a lot of the interventionalists in Voyager, especially in the United States, said, we're not sure we want to participate because we use DAPT all the time. And we're not sure we want to randomize somebody after a peripheral intervention away from DAPT. So it was hard to do the study. And so we said, okay, we're going to do rivaroxaban versus placebo on top of aspirin, and then you get to add clopidogrel if you want so that we could enroll patients. Now that trial is unlikely to happen again, unfortunately, because we have these data and it's hard to redo some of those things. But I think what we've left our practitioners hopefully with is options. We know that if you want to use aspirin and clopidogrel, you can do that. It's just that if you added an antithrombotic, you could do that for a short period of time. And then if you added the antithrombotic from the start for the long period, you're going to get more of a benefit. So I think that's the way we answer it just because of what we know.
Right. The next question is, how should we manage patients on TAPT with bleeding risk? Now, I'm assuming with TAPT, we're talking aspirin, clopidogrel, and maybe adding rivaroxaban. I don't know in your practice, this is one of the things I have routinely tried to avoid. I don't know, Dr. Aronow, how do you feel about using triple therapy in your patients?
Yeah, no, so this is a really great question. I had a little notation about this on a couple of my slides, and I didn't have time to get into it, but if you look closely at the inclusion and exclusion criteria for trials like Compass and Voyager, so all the patients at high bleeding risk, they were out, right? So, so we don't really know. I mean, that's a data-free zone. So, I mean, I would probably tend to be a little more conservative with that patient population, because when we saw bleeding as measured and adjudicated in those trials, it was in people who were already at low bleeding risk to start. So I don't think in the high bleeding risk patients, we really know. I'm a little personally, I'm not advocating this strategy, but I'm saying in my own practice, at least, I'm a little bit hesitant in a high bleeding risk patient to put them on TAPT.
Teresa, you're doing a wonderful job. I want to add one thing that, we should probably thank Manesh, who presented Euclid, that it was a negative trial. Imagine how complicated life would have been if you had ticagrelor to be a positive study and you had DOACs come behind it. That would be a real mess. So thank you, Manesh, for having 11.2% superimposed beautifully over 2.5 years. So I think that was fantastic. So having said that, I just want to throw in some spice into this, and maybe I think the viewers are interested in what you do in your real practice. And I know the cases were interesting, but the real question is that if you have a patient, say post-ACS, who is tolerated DAPT, and you do a SFA, a routine mundane intervention that goes very well, are you likely to disrupt that? Say it is 8 months post his ACS and for a non-STEMI. And this is a question to Elissa, because I saw she was very adept in presenting 2 doses of rivaroxaban in her case. I mean, when she saw a thrombus, she suddenly used a larger dose, and in the chronic setting, she used a smaller dose. So I think there are some impacts, the angiographic presentation, the success of the procedure, all of that could impact it. And I'm going to complicate that by saying that imagine a patient with ACS who has had a successful post-treatment course on Clopidogrel or ticagrelor plus aspirin doing extremely well, and you do an SFA intervention, and suddenly you are compelled to take out the ticagrelor and substitute that with rivaroxaban or clopidogrel for a few months, because I think in Voyager there was a substantial number of patients, a third, who had some exposure to clopidogrel. So what would Elissa do in that situation?
So, this is interesting because I think my practice has evolved over the last 2 years with this data. I think before I would have only done dual antiplatelet. I, on high-risk patients, do give them a month of triple therapy. And then if they're post-ACS 8 or 9 months out, you have to weigh the risks and benefits beyond that. But certainly let's say if you have, I think it depends on the disease. So if you have a patient with CLI, where wound healing and patency in the first few weeks is critical, then it is entirely plausible that a month of an anticoagulant on top of the background of dual antiplatelet for a stent could hasten wound healing and get you out of Dodge faster. If you're dealing with a claudicant that you're just doing a mundane SFA intervention on with no significant sequelae, I don't see any reason to switch the therapy.
I think that's very reasonable, and I'll just add that like everything, we're all colored by what we know. So if that coronary intervention was prox LAD, left main, and let's say large territory, I'm hesitant to change before I do a peripheral intervention. I'm hesitant to drop a DAPT. One of the things people talk about now is even when do you drop DAPT because of bleeding risk and stuff. So I think even in a post-MI setting, unless I'm in a post-MI PCI setting, unless I'm driven to drop DAPT, I don't do that in the first year, even though I know there's oodles of data that are coming and people arguing for that, especially in where the risk is. Once I move away from that, as Elissa just highlighted, depends on then I do the same thing for the peripheral. Is it a CLI case? Is it really a high burden atheroma? Am I trying to do something? It's a claudicant. You did it at 8 months. Then it's like, what's the coronary versus? It's almost nicely. She nicely said it's a Mace versus Mail decision in my brain on what's driving what I'm doing.
And Herb, the issue that I specifically want to bring up is that if you do want to go in the scenario I described to triple therapy or add rivaroxaban, you also have to alter the P2Y12 agent. And I think that also throws in an extra degree of complexity into this case. So in what you do in your real practice, I won't give you a particular scenario, but if you find a patient who is not on clopidogrel, maybe on prasugrel or ticagrelor post-PCI, and you are doing a peripheral intervention, what do? You just switch that to clopidogrel and add a rivaroxaban? Well, I'm just for routine cases. I'm not asking the extreme of thrombus or graft.
Yeah. No, that's exactly what I do. I usually switch to a less potent P2Y12 inhibitor with my aspirin and rivaroxaban. So yeah, I don't know that everybody does that, but I think there is a little bit. I think people are a little bit skittish about continuing with more potent P2Y12 inhibitors. I don't know. What do others do?
You know, it is not customary to ask the moderator a question, but Teresa, because you see those patients that we probably miss, and you see them in the clinic, and say, imagine you see these patients, 3 months later after the intervention, and the intervention has gone very well, the patient has done well. Just for secondary prevention, if fellows and attendings see those patients in the clinic, should we just then add rivaroxaban 3 months after their uneventful peripheral intervention? Do you do that for long-term gain?
I will say it's not necessarily one of my most strict practice patterns now. I do think there are patients in whom we do that. One of the things that I find I'm faced with a lot with rivaroxaban and with some of these other medications, particularly I have predominantly an inner city practice, is looking at compliance. And I was actually going to throw that back to you guys as a group and say, I know if I give somebody clopidogrel, I get a few extra days, right, of antiplatelet activity if they miss their meds here and there, which I don't get with rivaroxaban. And do you think about that if you have patients who are, less than faithful with their medications? I mean, I know that's how we look at rivaroxaban versus warfarin in our VTE patients, right? I get a couple days grace period if they happen to not be the most compliant patient. How do you feel about that? I mean, that almost, in my mind, makes a better case for using some DAPT after your high-risk interventions if you think they may not go home and take their rivaroxaban, or they may not afford their rivaroxaban, those type of things. Does that play a role?
Yeah, so I think that my belief is, I think it's a great question, and I think it's driven by, can they get the therapy? Mm-hmm. So what I mean by that is not if they miss a dose or not, but if my patient can't afford or get any therapy, but let's use rivaroxaban in this case versus clopidogrel, then I agree with you. I think it's hard to prescribe something that's going to be, in honesty, hard for them to get financially, and they're not going to get. Regarding like what happens when people stop therapy or they don't take a dose, there, I feel less driven by that because, look, I have data where I'm sure in the trials people didn't always take their therapy, and I'm sure they missed doses. Like the belief that they were 100% compliant is unlikely. And then we counted all the events. And so my sense is that the events were less in the arm where we asked them to get it. Now they were getting it free of charge. So if they can get it and they were taking it, that was probably good. This gets back to the ticagrelor question. If I'm spending the nickel on ticagrelor versus rivaroxaban versus prasugrel, then I'm going to get back to deciding if I think Mace or Mills driving it. But if I think about missed doses, then I just really think about, can they get the therapy?
Tony Gutierrez from Duke, I don't know whether Manesh was on that paper, recently published a phenomenal paper on EMR-based automated pathways for identifying these patients. It was mainly directed towards atrial fibrillation and showed that not only new patients got identified, a substantial number, over 25%, and also the compliance was better. I think some of those strategies could be applied, and I think Teresa addressed that issue. I want to ask one more thing. In the coronary in the coronary side, it is becoming more and more clear, and whether you agree with me or not, and with some editorials and data, that the bleeding risk is actually the driver and not the ischemic risk in the selection and duration of thrombotic therapies. Is it something that you guys think of in terms of bleeding risk? I don't want to point out each question, but Sartaj, Gail, and Praveen and others who I know quite well have been asking this question repeatedly. That's that how does the bleeding risk and what do you use to assess their bleeding risk? Is it the regular Hasbard bleeding score or the ACC risk estimator for bleeding, whichever? Elissa, you have a favorite one or that you use? Because you actually were the proponent of triple therapy, so I'm sure you have a elaborate way of assessing the bleeding risk.
I like the Hasbard score. I also go by the clinical history too, because a lot of the patients have concomitant CAD, so they've tolerated aspirin and Plavix at some point, or they have AFib and they've tolerated anticoagulation in some other form.
I think at least to add to that a little bit, it is important to point out in all of these clinical trials, I mean, we've all been there and choosing who we enroll, we do enroll the low risk bleeding patients. So I think you do have to have fairly, you have to be confident in the low clinical risk. The other thing that I would say about rivaroxaban and you know, every time I open a new manuscript, there are new drug interactions that we have not necessarily previously identified or previously been aware of. This is especially coming to light in some of our, you know, newer cancer therapies and things like that. And I think making sure, you know, if they're on the standard, you know, 5 cardiology med cocktail, that's okay. But I do think you have to also be very careful and look very carefully at their medication list to make sure you're not going to have any concomitant interactions with your DOAC if you're going to choose triple therapy in these patients.
Teresa, it is evident, and let me just say it out loud, that it seems that you are not jumped onto the bandwagon of adding rivaroxaban to everyone. Well, we have in some ways, and I'm sure, you know, the jury is still out. The question also is that, do you consider, and this is a very quick yes and no and rationale question for the 3 speakers, and also to you, Teresa, is that do you consider each of the other DOACs equivalent to rivaroxaban, or you would actually switch patients to rivaroxaban, or apixaban 2.5 is good enough, or that is something untested territory? I know this is off-label, but because it's a CME event, I can ask you those questions. So imagine a patient with atrial fibrillation who's been managed with apixaban, he undergoes the peripheral interventions. The question, these are very specific questions, and my fellows asked me at the clinic, so I thought I'll refer them to you, and that was the motivation behind this very elaborate scheme to invite you all tonight. So, Manesh, starting with you, what would you do? You prefer? You have a preference? How do you see the data, and what do you do?
Well, so simply I do get asked this, and this is important because so the dose of rivaroxaban for AFib is 20 milligrams or 15.
Exactly.
Dose of apixaban for AFib is 5 milligrams, not even 2.5. You know, out of the 18,000 patients, 18,000 got 5 and 400 got 2.5. So I see a lot of underdosing of apixaban for AFib. And if you think 2.5 of apixaban is the same dose of 2.5 of riva, that's a 10-fold difference. So I would just be very careful about even if you think the drugs, and I'm not suggesting they don't work the same way, the problem is thinking the dose is the same. The dose equivalency doesn't exist.
And that is an excellent point, because we are seeing underdosing for AFib. And I think this has become a real problem because of the multitude of doses of rivaroxaban, and not to throw in the DBT dose in the middle of all this, which is also different from each one of those doses. So, Herb, what is your strategy, and how does your system, which is a large system, organize all this? This is EMR based, and I know at Yale there are some automated schemes to do it, but I'm not familiar with how you guys manage it. Or there's a clinical pharmacist that tags along each patient.
So, you know, in certain clinical units, certain nursing units, we certainly have clinical pharmacists that are with us, and I find that to be tremendously helpful. But I think in general, I'd like to see us move in that direction where we're a little bit more organized through our EHR with prompts. We don't currently have that, but you know, for all the reasons you mentioned, I think it would be tremendously helpful. So for those who already have that, I'll just say I'm a bit jealous.
the one last question I have from my side, because I have a list of about 5, so I'm the last one, is that, you all talked about antithrombotic therapies, and I think some of the topics guided you towards it, but there's an element of more intensive lipid-lowering therapy with PCSK9 inhibition, which I think the magnitude in PAD patients is substantially greater and very, very impressive. How are each of your systems, and starting with Teresa and then Elissa and then Herbert and Manesh, how are your systems handling the new intensification for at least the polyvascular patients? And is there a overall risk estimator for these patients that would combine the polyvascular risk? Because we are doing a little project with the VA data looking at the SMART risk score. I hope you know it. This is one of the few rare secondary prevention risk estimators that include both PAD and CAD together. I encourage you to look it up, and there are some validations that have been published in the US. The question goes down to the fact that each one of these therapies that I mentioned, lipid lowering and antithrombotic, have probably a greater magnitude of benefit in these patients. So going back to the question is, how does your system or healthcare system or you as a practitioner tackling these issues? Teresa?
So for myself personally, if I have somebody that I identify as being high risk or who I feel like I'm not getting the job done from a lipid lowering standpoint, or they've had an event with our current therapy, that's the point at which we'll escalate. We have 3 very active preventive cardiologists in our group, and I will usually refer to them for instituting the PCSK9 inhibitors and following those patients longitudinally.
Elissa, do you have an easier path towards PCSK9 for these polyvascular patients in your system?
So my system is your system at the VA. And the pathway is the non-formulary pathway, which can be long and cumbersome. However, I do think it works pretty well. And it's quite straightforward. I mean, if the patient fails high-dose statin, then moving on to that makes a ton of sense, and is actually quite easy to get.
Herb, do you proactively seek out these drugs?
Yeah, well, I mean, I think it's worth saying first that maybe the reason that none of us spent a whole lot of time on this tonight was that they're just much harder to get our hands on for our patients, right? I mean, the bar is that much higher, and so it's not as hard to get dual pathway inhibition in place. But when I have a patient who I can't get to goal or who's not tolerating a higher dose or any dose of statin, I'll certainly add a cholesterol absorption inhibitor. I'll add ezetimibe, but I'll refer to preventive cardiology as well, and that's usually the mechanism we use in my division to get people to a PCSK9 inhibitor.
Manesh, I will ask you a slightly different question, because my fellows are texting me some questions. That means I don't do a good job answering them live during business hours. And they are encouraging Manesh Patel to answer them. One very good question is that when you see a PAD patient and they're on a specific SGLT2 inhibitor, do you feel compelled to switch them if they are on canagliflozin, or do you believe in that? That's your personal opinion. The data, of course, may be quite clear. And the second is the device therapies you use in your endovascular revascularization. For example, we're not going to insinuate anything, but if you put a long Viabahn into someone's leg, would you be compelled to give a higher dose? Second is that the IFUs of some of these drug delivering tools have specific DAPTs mentioned in their IFUs, like 2 months after impact and 3 months after INNOVA. And now you're doing something very different. You're giving them 2.5 milligram diperoxaban. So how do you actually navigate those that meshwork of possibilities?
That's great. I'm gonna see if I can do rapid fire answers. Okay, so SGLT2 inhibitors have had, some agents have had minor amputations of the toes and others haven't. My review of that data does look like, at least to me, there seems to be a risk on some of those in the diabetic patients, especially I believe with yeast infections or other fungal infections. So I think you have to be careful about that, but the cardiovascular risk benefits generally outweigh stopping any of those agents. Next, drug-coated products. Okay, so that's a place where we've learned we need to follow patients longer. The entirety of drug-coated products possibly being adverse to our patients was driven by not having enough long-term data or the pharmaceutical data that was treated with them. That being said, now we have a randomized trial in the New England Journal from Sweden that showed no harm. We have a variety of other observational studies that we best managed and say no harm. During Voyager, we said, look, here's the package insert. Anywhere from 1 to 6 months, we'll leave it to the investigators. Read the IFU, do what you want, use what you want. Connie Hess has presented at TCT that the drug-coated product analysis from Voyager showed no difference in outcome based on drug-coated product or not. And of course, drug-coated product patients who got dual pathway benefited just like all the other patients. Now, Viabon or a coated product, non-coated product, but let's say something that's not mesh, but it's not a stent, but it is mesh. We have seen observationally that those patients have higher risk of thrombosis, but it's hard for me to change the dose, not knowing the dose they should go to. With warfarin, we could go to an INR we felt comfortable with. With the new agents, it's hard.
Teresa, you did a fantastic job moderating. My job was to throw in enough ambiguities at the very end so I can justify another webinar and having you all over again to ask these very difficult and exciting questions, which I think are very pertinent. As you can imagine, this, if you take, Dr. Gibson says, if you put all these drugs in order and he has a mathematical calculation, the number of permutations you can come up with is astronomical. And I think there is no way to wrap our brains around them. So Teresa, over to you and final thoughts.
No, I think this was an outstanding presentation. I want to thank all three presenters. I would encourage you to go to the website, look at some of the previously recorded sessions, and please remember again to join in 1 month for the upcoming discussions on structural heart disease. And thank you for your time this evening.